Thank you so much for having me. As Christina said, I work with Nick and Nina up at John Hunter Hospital, and I've been given the task to cover management of respiratory secretions in 10 minutes. So that's like nearly impossible, but I'll just give you a really quick snapshot of some of the things physio can do, and then hopefully talk more a little bit in the questions. And of course, open to any questions later in the day as well. So my primary contact with motor neuron disease patients is on the acute respiratory ward, so primarily when they're unwell, unfortunately. But recently John Hunter's also been involved with the Enable pilot project, trying to improve access to M&D patients to access cough assist machines, which has been a struggle in the past. And so I'll talk about that briefly at the end, and there may be some other professionals here today that have also been involved in that. So we know patients with neuromuscular diseases, and particularly motor neuron, have difficulty managing those airway secretions, and Nick alluded to that at the end of his talk. The reason that patients with neurological weakness have difficulty with managing secretions is due to a loss of inspiratory and expiratory capacity, due to both muscle weakness, but also over time not being able to take a nice big deep breath in means that there's some changes to the chest wall, rib cage, and lung compliance itself. And as that increases, those already weak muscles then have to overcome that increased mechanical load to ventilate appropriately. And also we need to be able to take a nice big deep breath in and force that air out really hard and fast to have a good cough, which someone just demonstrated beautifully over there. We've also mentioned today a lot about the bulbar symptoms that are present in motor neuron disease, and this can directly impair cough as well, which I'll talk about in a moment. And we've also briefly touched on silarrhea, so that increase in oral secretions, which increases the risk of aspiration, and so being able to manage those secretions is really important. It can be a really awful thing for patients to have to deal with. I've had someone come into their clinic with, big dad handkerchiefs just shoved into his mouth because that was the only way that he could get out and about managing his oral secretions. So it can be stressful for patients. All of these things, weakened muscles, reduced compliance, inability to cough, upper airway dysfunction, and increased secretion obviously put our patients at a much higher risk of developing respiratory tract infections and respiratory failure, as Nick talked about. So being really mindful of that, teaching patients and carers early about airway clearance techniques is vital. So we've learnt today we take conversation for granted, our ability to breathe when we're asleep for granted, but also our cough. So we do it throughout the day without even realising. It's a reflex that's a key defence mechanism that we have to protect airways and remove secretions. There's 3 specific phases. Again, like I said before, the ability to take a nice big deep breath in, to close off our glottis and increase our intrathoracic pressures, and then really turn on our expiratory muscles to force that air out hard and fast. And doing that shears those secretions and any foreign bodies or particles up to the oropharynx, where they can then be swallowed, or if there's an increased volume during illness, that can be removed by a suction. Unfortunately, with motor neuron disease, there's usually impairment with at least 2 and sometimes 3 components of that cough reflex. So reduced inspiratory muscle strength will mean that the patients can't take in a big deep breath towards their inspiratory capacity. They can't close off their glottis due to those weak laryngeal and pharyngeal muscles. And they don't have that abdominal and expiratory muscle strength to force that air out hard and fast. So when we're assessing patients' cough, I say to my patients, can you try and just show me your cough so I can hear what it sounds like? And it might be this. Okay, that is never going to be effective to clear airway secretions, and that can happen, as Nick said, quite early on when there's respiratory muscle weakness. So what is an effective cough? You or I would cough with a peak cough flow of somewhere between 360 to 1.2 litres per minute, which is effective. A patient with motor neuron disease or a neuromuscular condition, we know need about at least 160 litres per minute for an effective cough. And that's based on some studies that looked at successful decannulation of tracheostomies and extubating people. Realistically, patients need 270 litres so that when they're unwell, they don't fall below that critical threshold of 160 litres per minute. Patients who are having a respiratory tract infection, who may be dealing with increased thickness or tenacity of their secretions, may even need faster cough flows to be able to clear that secretions appropriately to avoid sputum plugging. We can measure peak cough flow quite readily and easily with a face mask and a peak flow meter. And so we can get an idea when we assess our patients if they're falling below that critical level of 270 litres per minute, then we need to probably start thinking about some cough augmentation strategies and teaching patients and carers how to facilitate cough. There are lots of physio treatment options for improving ventilation and secretion clearance that I don't have time to go into today. But if we have reasonable respiratory muscle strength, we can start with basic things like deep breathing exercises, talking to our patients about positioning, correct seating, mobility and exercise. As respiratory muscle strength decreases, we can start to look at more manual techniques like lung volume recruitment manoeuvres, and that can be achieved using a manual resuscitation bag and a one-way valve. And it's called breath stacking, where you can get the patient to try and take a big deep breath in and then repeatedly deliver inspiratory volume so that they stack one breath on top of the other before then doing a manual assisted cough to really increase those peak cough flows. As respiratory muscle strength continues to decline and their peak cough flows fall, we can initiate mechanical insufflation, exsufflation, or the cough assist device. When patients come to us and they're unwell, we can also look at things like teaching patients and carers manual techniques like percussion, vibration, postural drainage, as well as assisted coughing techniques as well. We always work very closely with our multidisciplinary team to support education around speech and swallow and trying to minimise the risk of aspiration, and setting up suction equipment when that's required as well. Whether it's just a yanker sucker to clear that volume of oral secretions, or if patients need further suctioning when they're in hospital. We also chat to our medical teams if mucolytics may be beneficial, and certainly if silarrhea is becoming an issue for our patients. Mechanical insufflation, exsufflation has been revolutionary for us in our ability to increase patients' cough effectiveness. And we use a cough assist machine, which I'll show you a picture of in a moment. But it works by providing a deep insufflation or positive pressure and then rapidly shifting into that expiratory phase to generate high expiratory flow rates. So again, nothing difficult about it. It's just simulating a normal cough mechanism. By giving patients really nice big deep breaths in, we can overcome that microatelectasis, give their chest wall and their lungs a nice big stretch, which patients often feedback that it actually feels really nice. They're sitting at really low tidal volumes and you can give them some really good deep breaths. Patients often say that that's actually really comfortable for them. And there is good evidence for the use of this device in neuromuscular disorders, but it can sometimes not be tolerated all that well in patients with severe bulbous signs, and that's because there's often collapse of the upper airway during the expiratory phase of the manoeuvre. So we just need to trial and determine if peak cough flows can be achieved in those patients and if they can tolerate it. So this is the Philips E70 device that's most widely used. It's got a lovely electronic interface that gives great feedback to the patient. They can sort of watch the insufflation and the exsufflation cycle, and it also tells us about their peak cough flow with every cough that they do, and we can lock all of the settings. So from a safety point of view, that's really important as well. They're light, there's a battery pack, they're quite portable if people go away, and I know Lynn was talking about Alex using his and being a real advocate for the cough assist machine and found it very helpful. We can deliver cough assist via a mask, which is probably the main way that we do it, but patients with tracheostomy, there is a tracheostomy attachment as well, and if patients are mechanically ventilated, we can also do it via the endotracheal tube. We can set it with an automatic or manual mode, and we preset all the pressures and timings so that we can certainly titrate it to the patient's comfort. And when patients are sick, or if we need to increase their peak cough flows, we can certainly combine it with other techniques such as abdominal thrusts and other manual techniques. So the Enable Pilot project was a trial to determine the feasibility of introducing paediatric and adult funding criteria for the cough assist device for patients with neuromuscular disorders and spinal cord injury. We were one of 7 lucky sites to participate. The machine itself is about $10,000, so getting funding for that was notoriously difficult for this patient population. We were provided with 2 machines from Enable, and in combination with the devices that we already have, we were able to assess our patients, set them up, send them home with a device, let them trial it for a month, and hopefully if they were happy and using it most days of the week, we launched an Enable application for them. The most recent data, Enable had 23 people apply from the sites, and it's just about wrapped up. So they tell me that they'll be reviewing all the data that's come from that project. So it's a bit of a watch this space. Hopefully that will proceed, but we'll just have to wait and see how the feasibility of that goes. Our patients were referred to us by our respiratory specialists or the respiratory physios on the ward. We saw them as outpatients over multiple sessions and titrated their pressures and setting. And as I said, we let them trial the device at home with their carers for a 1-month period and ran compliance reports similarly to what you do with NIV. We've done 5 applications, all have been successful, and we've got a couple in the works. Whether or not we'll get through them, I'm not sure. But so that's a very, very quick wrap up of physio. Thanks, guys.